Okay, good afternoon, everyone. I'm going to go ahead and get us started as people join us. My name is Allie Wells. I'm the Communications Director at the Foundation for a Healthy Kentucky. Thank you for joining Health for a Change, Navigating the Changing Public Health Data Landscape. I've got some real quick housekeeping notes to go over with you all. If you have any questions during the webinar, you can put them in the chat box or the Q&A. There are no pre-approved CE credits attached to this webinar. However, I can provide a certificate of attendance for joining the live webinar today and staying on the full time. I will be able to tell if you log out early. My email is up on your screen right now. If you want that certificate, please email me this afternoon or in a few business days. The subject line should say request for certificate of attendance, and the body of your email just needs to say your name. I'll also include these instructions in a follow-up email after the webinar today. So to tell you just a little bit about the Foundation for a Healthy Kentucky, we are a nonprofit organization funded by an endowment that aims to transform our state so that every Kentuckian has what they need to live a healthy life. Our mission is addressing the unmet health needs of Kentuckians, and our two focus areas are access to care and children's health. We do our work through policy advocacy, we build partnerships and bring together constituency groups, we fund research and data, and we fund and support community interventions and projects to improve the health of Kentuckians. I'm going to stop sharing my screen now. So data is something that's really important to us at the Foundation. It's a critical resource for making informed decisions to improve the health of our state. But the landscape of public health data has changed a lot recently. So I'm excited to introduce you to our two speakers today. Dr. Angela Carmen is an associate professor in the Department of Health Management and Policy at the University of Kentucky College of Public Health. She is also the Foundation's endowed chair in rural health policy at UK. Mary Elizabeth Pendergrass is a public health policy and practice apprentice at UK's College of Public Health. They are both leaders of Team Up, a public health academic practice collaborative that was created to serve as a bridge between academia and practice in public health. They're going to tell you more about Team Up later in their presentation, but the Foundation is really proud to be partners with this initiative. So with that, I'm going to turn things over to them.
Thank you, Allie. We appreciate being invited to participate today. Navigating the changing public health data landscape is something that we're all working toward and trying to make better, and many of us have had some big changes lately. I appreciate the introduction. I did want everybody to see who Mary Elizabeth is. Mary Elizabeth has served a critical role in developing this webinar for you, and she is currently the Team Up apprentice, and we will share just a little bit more about that later on. So thank you, Mary Elizabeth, for everything you've done for this. And we'll go ahead and get started. Here's our agenda for today. We want to start out with just a little bit of information about the importance of public health data. We feel like this particular audience, you're probably very comfortable with that, but we wanted to just hit on a couple of things there. We'll later move into the changing public health data landscape. We've just addressed a couple of things there. We want to spend the majority of our time together with identifying available data sources, and we'll tell you the process that we went through for that, and we'll share several of those with you. Please stay with us through the end of the webinar, and please don't feel like you have to write down the available data sources that we will share. At the very end, we will give you a QR code, and you can have access to all those links. So you can just sit back and participate that way. We'll also share some specific tools. Mary Elizabeth and I are really big on developing toolkits. So we've developed a toolkit for navigating this data landscape, things for you to consider. Also, we're going to touch on some data as part of a broader context and a little bit of actionable data and next steps. So that's what we're going to plan to do today. And again, don't forget to stay with us till the end and get that QR code for all the links that we will have. So when we talk about the importance of public health data, this comes from CDC's public health data strategy. We use it to detect issues, to monitor the status of health and the status of different health conditions. We use it to investigate and respond to particular things, to inform people and disseminate information, and also to be response ready should there be a public health crisis of any kind. We talk a lot about data-driven decision-making. So many of you are trying to find data to help with some of these specific issues. So you can be looking for a community health assessment and a community health improvement planning strategy. So that involves data. strategic planning of your particular organization. Maybe it's grant funding or developing an application for a grant, program evaluation, looking for best practices. There's all sorts of different reasons why you would need specific data. I want to pause right here just for a second and invite you in the chat to list any other needs that you have or reasons that you are involved in searching through the public health data landscape right now. So I'm going to pause for just a second and see if we have anybody put anything other than these areas, the CHA-CHIP, strategic planning, grants, evaluation, or searching for best practices. If you could list those. Oh, that's a good one. Refuting public health myths, reaccreditation. Oh, there's a lot of really good ones popping up. Thank you for that. We will hang on to that list, and we want to make sure that the things that we're doing from a team up perspective are helping you meet those needs. So thank you so much for putting those in the chat. Let's move on to our data challenges. Oh, I skipped one. I'm sorry. Thank you, Mary Elizabeth. Stratifying populations and communities. Many of you are working on determining what level of data that you need. And depending on the granularity or the getting down to that zip code level that you need, it can make your data search even more challenging. So we want to be able to provide sources and let you know at which level they are available. So some will go to all the way down to the zip code level. County level is usually where we spend most of our time with data. There's, of course, state level data and national level data. I wanted to say one thing about this before we move on. And that is, I have witnessed in practice people that are just so good at digging out the data that they need, and they are intent on going to the lowest possible level of granularity. And that is fantastic. But one of the things that we've been looking at lately is it seems to be a little more rare that the decisions on what to do with that data actually address a lower level of granularity. And let me give you an example. You may be looking at obesity data, and you may want that all the way down to the zip code level. But and hopefully you can find what you're looking for. But sometimes what we then go back and see is that any sorts of interventions or policies or initiatives of any kind don't necessarily address the most granular level. Meaning, if you saw a particular neighborhood that had higher levels of obesity, are you going to that neighborhood? Or if it's age levels, if you see that our adolescent age group, our elementary school kids are suffering the most from whatever public health issue you're researching, are you developing an intervention that matches that? So sometimes you are kind of held back by available resources to be able to do that. But I guess I just wanted to mention it from the perspective of, if you plan on delivering your policy work or your intervention work at the county level, maybe finding that data will meet your needs, and going on down to the zip code level might not necessarily add anything. I know that's probably sounds backwards from what you're mostly told, but I'm a practitioner at heart, and I want you to be able to get on to the action steps. So that's where that comes from. Okay, so we can move on to our data challenges. I think if I ask for hands, which there's quite a few of you, so I won't take time to do that, but I bet if I did, we'd see a lot of hands that this is what you're finding when you're out there looking for data. Could that be true? A page not found, the page you're looking for was not found. A lot of the things that you've gotten used to are currently not available. Oh, I'm seeing lots of thumbs up. Yes, so we've endured that too. So let's go on and talk about some of the possible reasons for that. There's a lot. CDC has the Data Modernization Initiative. So there's lots of things being done to modernize the way data is pulled. So some of that could be happening. There's always technological changes, updating software and the way in which we were able to access data. So that could be part of it too. Oh, I see a great comment in the chat about data suppression because you're unable to get rates for a smaller community. That happens all the time. There are changes with artificial intelligence, again, about disease forecasting and different ways of doing surveillance. We even have changes at different times and especially state to state on what is a reportable disease and where that information goes. So those are just some of the things. There's lots more that can have our data landscape changing. So let's show you what we did. One of the beautiful things that happens when you are working from a university setting, which I am, I'm currently in the College of Public Health, is there are people with all kinds of expertise that walk these halls. So when we talked to Allie about the potential for doing this webinar, my first stop was just down the hall for one of our biostatisticians. She spends all her time enmeshed in data. So I said, where do you get your list of data sources? And this is what she gave me. It came from the Division of Epidemiology and Health Planning at the Kentucky Department for Public Health. And you notice the date on it is 2018. So this is where we got started. We utilized this 2018 Kentucky Public Health resource, and we checked every single resource that's listed to see if that data source is currently available, but at a different length than what was listed, or unavailable. So that's how we got started. So Mary Elizabeth did all this checking and looking through that, and what we found was just a little over 20% is available at the link that was listed, and 33% were available but at another link, and 45.8% were no longer available. Okay, so that's how we got started. So what I want to show you is some of the examples of what's still available, and again, I will give you that that list at the end. Right now, you can still get the National Crash Outcome Data Evaluation System. This is available at a national level. It's data on transportation and traffic safety. So these are really good pieces of information, but you won't necessarily be able to get it down at the county level. The Environmental Public Health Tracking Network is also still available. You can get national and, depending on the metric, state level data in a variety of different health and environmental types of issues. Hospital inpatient discharges and outpatient services databases. You can learn a lot from what kinds of issues our hospitals are dealing with. Again, national data is available, and state, depending on the metric, for hospital services and discharge data. Those of you who know me well know I started out in the hospital world, and we used to pull information from that to see what was going on in other facilities. So National Birth Defects Prevention Network, that data is available at the state level, so you can get information about birth defects. The Kentucky Cancer Registry is also still available, and that is at the state and county level. You can get cancer incidence and prevalence data. Here's one that we almost took out, but we wanted to show this to you. Here's an available source. You can still go in and get childhood lead prevention program data, but look at the date that the data is covering. It's back in 2002 and 2003. That particular data source, at least for our searching, we could not find a more updated one than that. Could it provide you with some information? It's possible, but please keep in mind how old it is. This one is also just a little bit different, pregnancy risk assessment monitoring system. This is a data set that CDC has, but it is only available on request. And you might run into that with several different types of data sources that you have to put in a request. It's not usually any problem once you do that, but this is a source where the uses of the data are being tracked. People are trying to see if it's useful for those people that need it. So don't hesitate to fill out that request if you need to. We also found the reportable disease surveillance system that will provide information at the state level is still available. And the National Vital Statistics Surveillance System, which provides information through CDC Wonder. I know our students use that a lot. at the state level, so you can do that. The Youth Risk Behavior Surveillance System is also available at the state level. And then, as is often the case, and many of you have put it in the chat, and I appreciate that, but as is often the case, once you start digging into data, you will find that there is more information, and it has been updated. So the selection that we pulled for this resource guide was the 2024. I believe someone in the chat shared that there may even be a 2025 out there. So 2024, this one, 2025 is probably out there. They're fairly similar, but what we have shared with you is the ones that we know are available at the link that was provided. Okay. So what I'm going to do now is switch over and let Mary Elizabeth talk a little while. In Team Up, we do a lot of data gathering for people. And while this resource was fabulous, what we wanted to do is provide to you some additional sources that we did not see in that document that we use a lot and what they provide for you. So Mary Elizabeth, you go right ahead.
Yeah, so like Dr. Carmen said, we just wanted to take a few minutes here and share with you some of the resources that we find. The partners that we work with enjoy using these, and they're fairly easy to access. So the first one we have is the CDC Places Local Data for Better Health. This reference has a lot of good data on the county level, which is usually more difficult to find. So you can see here in this little snippet, you would just type your county name in the search bar, and then it also has the comparison of the United States, so you can kind of see where your county lies. And another good thing about this data source, which you can see kind of in this image, is they offer accrued prevalence and an age-adjusted prevalence for all of the statistics. So you kind of have a good choice there, and we'll talk about the different types of rates a little bit later. There's also the Kids Count Data Center, and this is from the Annie E. Casey Foundation. This is especially useful if you're looking for data on children and education, because a lot of their metrics can be brought down to the school district level, because a lot of the counties in Kentucky have independent school districts as well. So that's super useful. And then this is another good one, the Kentucky Burfist data. So this is from 2023, so still pretty recent. And this report is actually by area development district, which is a good way to regionalize data and kind of understand, especially with those district health departments that might be in an area development district. But with this one, just be careful, because on the first couple of pages, it will list what counties are in each area development district. So just double check that the county that you're looking for is in the district that you're using. NIH state cancer profiles. This source is also excellent because you can view data on a map, but also in a table, so kind of whichever way is easiest for you. And this provides data on cancer incidence, prevalence, but also prevention factors. So they have information like mammogram rates or colonoscopy rates, so that's super useful. And that can go down to the county level as well. And then the last one we wanted to kind of spend a few minutes on is county health rankings. So this is a really excellent source. We use this one a lot. And I will move to this next slide here so you can see kind of how you use it. So you would type in your county in the search bar. And with this web page, you do want to be careful because there are multiple Jefferson counties, for example. So make sure that you're looking at Kentucky, because I've definitely gone to the wrong state before. And then once you're on the page, make sure you click the plus button. You can see kind of here in this corner here on all the pluses, and then the show demographic data, because that will show you all of the data. Because when you first enter the page, it only shows you kind of like the highlights and the most frequently used data points. But County Health Rankings has a lot of great data, and they have ways that you can compare across counties. So that's really cool, kind of see maybe how the neighboring county is stacking up with that same metric. And this is one where you do want to be careful too, because it will always say report year. So you can choose 2025, 2024. That does not mean the data is from 2025. That just means that that is the most recently collected report. So always double check on that. But they do update it yearly, which is great. And just another thing we wanted to mention is that County Health Rankings is undergoing some changes right now, so we don't know what's going to happen with that. but their funding source is changing. So if you go on their website right now, it should pop up with a survey, just kind of like asking how you use their data. So if you have a moment to fill that out, that would be great because I'm sure they're going to use that information to keep this resource going, and make sure that it's as best as it can be for our practitioners. So that's kind of all of the data sources that we found. And like Dr. Carmen said, at the end of the presentation, we'll have another list of all of those with the QR code. So don't worry about if we went too fast. But now I'm going to turn it back over to Dr. Carmen to kind of talk to you about navigating the data landscape as it continues to change.
Thank you, Mary Elizabeth. That's a lot of great information. And I do want to just reiterate what she said about county health rankings. I know there's some people that have had some issues with some of the ways that the data is pulled there. It has been a good resource for many of us for several years. It's been funded by the Robert Wood Johnson Foundation. And I believe, and somebody correct me if I'm wrong about this, that they will continue to fund that system through the end of 2026. So hopefully there'll be another funder come into play. If not, we will continue to work with you and see what we can do to replace that. So I told you before that Mary Elizabeth and I love toolkits. We love to put together things to help practitioners get to what they're trying to do as quickly and efficiently as possible. So this navigating the data landscape is just our attempt to do that. Many of you are probably very familiar with this. So this is you know how we are about acronyms. So this is something we came up with, some goals you can truly reach. And the letters of each one of those words are to remind us to think about the source of our data, the level of granularity, the year it represents, transparency, collection methods, and rate type. So we want to talk about those a little bit as we move forward. For the source, please consider looking at the following things when you are pulling a secondary data source. The rigor, meaning how did they go about collecting this? Who was the funding source? We don't like to think that there could be any impact of who the funding source is, but maybe there is, and maybe there were just data points that were left out because that's not the focus of this particular funder. So some of those kinds of things. And is this a source that you feel that you can trust for whatever reason? With granularity, we touched on that just a little before, but be sure you're looking at what level of data this is. Is it national? Is it state? Is it regional, county, zip code? Is there something else? I've seen data sources that will even go down to the street level in a neighborhood. So be sure you know what you're looking at there. Granularity, we also encourage people to always have a comparison metric. I have an assignment in one of my classes where I show them a raw data statistic and I ask them, is this good? The level of the particular health issue, is this good or is this bad? And so they're undergrads and they look at me like, I don't know. And they don't know because there's no comparison information. So when you have comparison information, you can at least go, okay, we're about where everybody else is, or we're doing better than other people, or we're about where the United States average is. It's some kind of a comparison, particularly if you're providing data for community programs or consortiums or something like that. Maybe people are not necessarily used to looking at data. They won't know whether they should be thrilled, horrified, or whatever. The other thing I have to mention is in Kentucky, we tend to be somewhere in the bottom of the 50 states, somewhere from 41st, all the way down to 49th. It depends on what the metric is. So I've been in counties before where they go, hey, we're doing the same as the state of Kentucky. Okay, and that does give you a comparison, a place to think it through, but don't stop there. Don't stop there. Be one of the counties that is doing even better than that. So those comparison metrics are important for that purpose.
And something else I wanted to add here, that I just wanted to mention is that when you use a comparison metric, you want to use the one that one data source provides. So for example, here you don't want to use Jefferson County from County Health Rankings, and then Google a different source for low birth weight, because you can't compare data from two sources because the collection methods are different. So just keep that in mind.
That's a good point. Thanks. And then we've hit this a few times, but the year is often very important. Considering the historical context when viewing data is important. This is one that we just pulled a little screenshot off of, and it is back from 2007. So in that time frame, were we as involved in vaping type issues as we are now? Does it include that? Does it not include that? Have there been many changes? The other thing is to explain to your group that you're working with, particularly if it's a community group, that this is common in data, that it's not always updated every year. I've had so many times when a community will say, that can't be right. We've done so much work since then. And they probably have. But whatever data point that you're working with is just not publicly available yet. So that it's just something to keep in mind. And then the data year versus the report year. This is what Mary Elizabeth was talking about when we think of county health rankings. And this is a snapshot from that. You go into Jefferson County, Kentucky, you pull the 2025 County Health Rankings report, you get some information. But as you look down into that, the data years used are 2020 through 2022. And again, it's just knowledge. You want to know what you're looking at. I never ever want to see a community get disheartened because of all the work that they've done and they think it hasn't made a difference. It very well could have, but the report has not come out yet that's going to show that. So you just want to stay tuned into that. Transparency. This is also important. Many times data is listed and you think of things, and it means different things to different people. So what we have to go into is, what did it mean to the collectors of this data? Did they define it? So this is a great example, poor physical health days. Okay, what's considered a poor physical health day? Well, it's defined as the average number of physically unhealthy days reported in the past 30 days, and it's age adjusted. And we know that age adjusted is simply done to be able to have a comparative analysis. So you can look at Jefferson County and look at a different county, and it's been age adjusted, so we can make a comparison there. But be sure you know the actual definition. I think the one that I have had the most pushback, and this is coming from a Chaw Chip arena where we're looking at data about counties, there will be something about the ability to have exercise opportunities. And sometimes it will say a county doesn't have any. And people don't like to see that because they know their county has some, but you have to go in and look at the definition of what they mean by an exercise opportunity. Is it a certain size? Does it have to be within a certain distance from the community that you're looking at? Those kinds of things. So it's really important to find a definition there. Yeah, this is another good transparency example. Severe housing problems. That conjures up a variety of different thoughts when we hear those words, but there's a definition that says percentage of households with at least one of 4 housing problems, and it lists that. So in Jefferson County, 14% of the households experienced at least one of the following, not all 4, but at least one of that list of problems. So that's a great example to think about transparency so people know what they're looking at.
Another example that I think of from the field is I brought data, secondary data, to a lot of community health assessment meetings, and one of the data points I had pulled was population with access to a large grocery store. And everywhere I went, the first question I got was, well, what does that mean? And so when we finally looked it up, the qualifications were like a certain number of square feet within a certain number of miles. And the way that that worked was not relevant for a rural area. And it turned out that the large grocery store could have been like a Walgreens. So kind of looking at those definitions can help you say, should I use this metric? So that's just kind of a thought.
That's a really good one. Then collection methods, it's important to take a look at that too. Many of our relied on that we've all used tons of times have questions in them where someone was to self-report. And we know that there is a self-report bias, which is a tendency of respondents to provide inaccurate responses for a whole variety of reasons. There are things that you don't necessarily want to self-report that you are dealing with, whether it's, you know, smoking or anything like that. So just realize if the data point is a self-report, think about that just a little bit, and what would be the natural inclination of some people on which way they would report. Would they report that they do more, like that they walk more or exercise more, or would it be something that they would report less, like maybe smoking? Respondent characteristics, who responded to the survey. If you're collecting data that way, that's more of a, if you're doing primary data collection, who responded and are they representative of the sample of the population as a whole? That's incredibly important. Many communities have done surveys to assess all kinds of different things, whether it's for a formal CHA-CHIP or just particular needs from a particular population. But if the only people who responded to you tell you that they're college educated and their financial situation is very strong or something like that, that might not speak to your community as a whole. So be sure to look at respondent characteristics, the number of people that have responded. I always ask myself, okay, who's talking to me here when I look at these pieces of information? Is it just a few? Is it from a very particular demographic, or is it much more cross-cutting across the community that's responding? And then reliability and validity, are they answering the question that was asked? Are you getting what you wanted to with the creation of your questions? So all those things are important. And then rates, people often get very confused about whether or not they're looking at a raw number or a rate. So I've had many people be very confused when I say a certain number is per 100,000. That's very common. They say we don't have 100,000 people here, and we know that, but we're turning it into a rate again so that it's comparable to other communities. And raw numbers often give people, that's often all you have, but you need to let them know if it's a raw number, because that means it's just the number that we pulled. We are not doing anything from making this comparable to other areas. Mary Elizabeth, anything else you want to say about that one?
Yeah, I think the raw number one is just super important because, especially in this example, you see Jefferson County has a much larger population than maybe Wolfe County would. So you see 1,000 versus maybe 10, and you're like, oh, Wolfe County's doing so much better, but that might be relative to the population. So just keeping that in mind, raw numbers are not as comparative, or not really comparative at all.
Yeah, that's great. Okay, now data as part of a larger context. And this is just something we couldn't resist throwing in. These two quotes, one we were able to track down the source, which I'm thrilled about. The other one I've heard in so many different places, I'm not sure who gets credit for that one. But the first one is no stories without data, no data without stories. And that's incredibly important. You don't want to move forward with the limited possible resources that you have, whether or not it's financial resources, time and energy. I always say, how many hands do we have to work on this? You don't want to move forward only reacting to stories, because there are times when stories are misaligned with what is actually going on. So you want to be careful about that. But again, if you look at only numbers without the stories, you can't get a sense of the impact. So that's just incredibly important. I've had so many different instances in communities where it was the story that finally helped us prioritize what we wanted to work on. So just keep that one in mind. And then the other one, I had the real privilege of working for the past couple of years with Dr. April Young here at UK, and in her expertise of substance use disorder. And she just drilled this into me: nothing about us without us. And what she meant by that is that if we are studying data about a particular population, in the instance of her research, people who have used substances, then we need to talk to them. We are not in a place to be able to decide for people, what will work, what will help, what do they need. And that's true for children and families and people suffering from all types of health issues. Talk to them, so see what they need before you spend those precious hours and those precious resources coming up with something. So both of those are really important to us.
Dr. Carmen, we have one in the chat. Somebody said that one of their favorites is data make you credible, but stories make you memorable.
Yeah,
It's a
yeah.
good
So you
one.
gotta have both of them. We absolutely want to be credible, but if nobody remembers that statistic because it was hard for them to picture the person that was impacted by it, then we didn't really get where we were headed. So I love that one. Love that one. So another thing we wanted to talk about, and I sort of mentioned this a little earlier, but how much data is enough? Because sometimes you can just dig and dig and dig and you're not sure if you can I stop now or not. So first, understand your audience and the end goal for your data collection process. If the end goal is for us to come up with a policy or intervention that will impact our county, then is county level enough? And then considering a mixed methods approach, and that's just a term that we use when we mean we want you to get the quantitative, the numbers, the statistics, but we also want you to go talk to somebody and get that qualitative and community input, and especially the contextual influences. And what we mean by that is things like, what else is going on in this community? We may be incredibly taken aback by numbers that represent obesity or smoking or teen pregnancy or whatever we're looking at. But we may find that there is something else that's happening in that community. And the quickest thing that comes to my mind is when the floods occurred in Eastern Kentucky. People were in need of basics, housing, clothing, food, really basics. It wasn't the time to unroll an intervention about obesity, possibly, or smoking. Well, we had to get the basics covered first. So just think that through. And then just huge in all public health work is collaborating with external partners. There are most health topics, most situations that are multifactorial. There's a number of different things that are going on here. And if there are a number of different things going on that are risk factors or contributors to a particular health issue, then it's going to take multiple areas of expertise or multiple people involved, hands, perspectives, all those things in order to make a difference. So we encourage you so much to collaborate with your external partners on anything that you're working on at the community level.
I also just wanted to add really quick about the audience. So kind of coming from a public health professional perspective, I love data. I want as much data as you can give me. But if you think about if you're bringing your secondary data to the community or to people who are not as well versed in reading data and interpreting it, you do want to make sure that you're not overwhelming them with too much, because if you hand somebody a sheet that's covered in numbers, they might just shut down and not look at any of it. So sometimes you have to kind of pick and choose what you think is the most important to share in those situations.
Oh, that's such a good point. And sometimes it's the beauty of the appendix, if you know what I mean, giving a snapshot of some of the biggest things, and then let all the data be accessible to people. But if you hand it out at a community gathering, you will usually find people just flipping through the pages and trying to make sense of it all. So yeah, you have to do some judgment calls there. And then often when you have a community coalition that's looking at data, they will prioritize some things and then break off into smaller groups. And then it's that smaller group that needs the more robust or the deeper dive into the particular area that they're looking at. So don't hesitate to do it that way. We're not suggesting you hold it back. We're just saying sort of be careful about overwhelming people. And then we want to think just a little bit with our final minutes here today, and then we'll open it up to questions about moving from data to action. One of the things that tends to be the hardest to do is after you wade through all the data that's out there and you pull in everything you can get and you identify what the community is concerned about, then you have to figure out what are we going to do about it. But I know if we had time to get stories from you guys, I know some of you would have had similar experiences to some things that I have had, where data points they were horrifying. They were absolutely horrifying with the number of people who, you know, hadn't sought out medical care in over a year, or people who teen pregnancy. Oh, that's a big one for me. The teen pregnancy numbers in certain areas, especially in Kentucky, are really, really high. But communities are not always ready to address just simply what is highest on the list, or the data point where we are most out of line with our neighboring counties or our state or the nation as a whole. Sometimes people are just not ready to take that on because something else is really, really important to them. And you've got to find out what the reasons for that will be. And I've often had people say, but we can't not work on teen pregnancy. It's such a high number. And we don't mean to imply that at all, but what we do mean to imply is, let's start out with something that people are passionate and ready to take on, provide them with the data for that. Let's see if we can't move the needle, as we all say in Kentucky all the time, or get some wins, and then circle back around and look at the data again and see if they're ready at that point to take on something else. And then often there is quite a bit of concern or struggle that people have with the implementation of evidence-based practice. What is evidence-based practice? How do I get my hands on it? I see a wonderful program, but it was only studied in an urban area, and I'm in a small rural county. Can I use that? What do I do? So we want to share with you some upcoming ideas about Team Up, and let you know how we plan to get kind of involved in this particular area, that implementation of evidence-based practice. Team Up is a public health academic practice collaborative. What it basically means is I am a faculty member here in the College of Public Health. I get the great opportunity to work with students. Mary Elizabeth first came to me as I guess I had you as an undergrad, and then you started working with me when you were a master's student. There's other students, some of whom you can see in these pictures, that are passionate about working with practice. They love that, being able to pull the data or pull the evidence-based practice and arm those people who are really going to the field every day to work on it. So our next big initiative, and what I'd like to get, if I could, is anything you're willing to put in the chat. A thumbs up, a no, I don't think this is the right direction, or any feedback that we can get. But what we're looking at is an assessment that we have done on the overarching needs in Kentucky. And then we're doing quite a bit of research on evidence-based practice, what you could do to improve teen pregnancy, or improve smoking, or improve cancer rates, whatever it is. A lot of the social determinants we're looking at, and be able to give you examples. This has been studied. This is how they studied it. This is what they have proven works, and then be prepared to help you with any adaptations. What can you adapt? What do you need to leave alone? And there's research out there that will help you do that. We can help you with that. For example, I worked on a project once about HPV vaccination, and there was a beautiful video that had been done and shown to patients within the exam room when they're there to see their physician. And what was found was people were kind of turned off by that video, because we were showing a video that had been created in a big city to a population of rural people. And people said, those people are not like us. I don't know if that would work or not. So we adapted that intervention by taking that same video and that same script and had it read by people who sound like me and people who are from rural areas. So people were able to relate more. And that kind of an adaptation is perfectly fine. You're not pulling out anything that's going to change the intervention. So we are looking as Team Up of that being where we can work as Team Up. We want to be able to provide something to our practice partners to help move you along in the work that we know you're trying to do, which is just improve the health of your community. So we've seen lots of thumbs up. Thank you for that. That's very, very encouraging. I even saw a couple of, hey, we could partner with you on that. So that's great too. I believe that was a former student I saw put that up. So that's even better. So now we want to stop talking a little bit and just see if you have any questions with the time that we have left. So Allie, if you'll help us monitor some of that just a little bit.
I can absolutely do that. So yeah, if you have any questions for Dr. Carmen or Mary Elizabeth, feel free to put them in the chat in the Q&A box. One I did want to pull out from earlier, how do you assess the likelihood that your audience will be receptive to or understand the data? I know Mary Elizabeth talked a little bit about not overwhelming them with it, but do you have anything else to add for that there?
Mary Elizabeth, you want to take that one or do you want me to do that?
Well, my first thought initially is that when we partner with communities, we purposely spend a lot of time in those communities. So even when we're not necessarily working on a specific project, we make sure we go, we talk to people, and really interacting with your audience and the people that you're going to be working with can kind of give you an understanding of what they might be receptive to, and the best way to kind of present it to them. That's my thought.
Yeah, that's great. That question reminds me of the way that I was taught a long time ago to do public speaking, and that was know your audience. Know your audience. So, I'm sitting right now in Lexington, and so I do not want to send out the impression that I know what people in another county would be receptive to. But my counterparts that work in those counties every day and will let me come and work alongside them, then together we can figure that out. I mean, I've had so many focus groups where the health department director will whisper in my ear something about a big happening in the county or a big sore spot, something that didn't work well once before, or something like that. They give me that information, and it helps me to tailor the way we present certain data. Please don't misunderstand me. I do not mean we're going to talk down to or anything like that, but we just want to pull out what they need, and then if they need more, we can do that too.
Someone made a comment in the chat about a recent meeting where they were talking about data, but a lot of acronyms were used, which was confusing. So what do you have to say about using acronyms,
Oh,
avoiding them?
that is so easy because most of us grew up in whatever, I grew up in the healthcare industry professionally, I guess, and there's a lot of acronyms there. We like to provide a cheat sheet in case we slip up and use the acronym. But I've even asked groups to, catch me if I did that and make me define it for you, because that's something we don't need to do. It's faster for us to call it whatever the acronym is. I can't even think of one right now, but rather than spell it all out. But that's not fair to the people who don't spend as much time in that box as we do. So cheat sheet is a good suggestion. Put it on every table and let people, if you slip up and say CDC instead of the Centers for Disease Control and Prevention, then somebody can figure out what that means. Please know that people won't ask. They will not raise their hands and ask. People just don't want to, they don't want to be the only one in the room that doesn't know what that means.
Do you all have any tips on finding or evaluating data sources that might traditionally be reliable, but in the changing landscape are suppressed or the focus of the lens is obscured?
I think I would just send you back to our toolkit. If you feel like things have been suppressed, maybe we can look for a different data source. I'd also want you to think really hard about what your end goal is. So that, is this a data source that you absolutely need, or could we get to that another way? We want as much quantitative as we can get, but sometimes it's not there and you just got to go ask the source. Nothing about us without us, and you go ask the people.
Yeah, and a lot of the sources we mentioned, especially from CDC, have some sort of tab right now that'll be like, this source is undergoing review. So a lot of them will tell you that they're being changed,
Yeah.
which is helpful, at least right now.
Thank you. I'm not seeing any other questions right now. Like I said in the chat earlier, the recording to this is going to be sent out to all of you. Thank you so much for joining us today. Thank you so much, Dr. Carmen and Mary Elizabeth. This was a great presentation, super helpful. I know it took a lot of time to put it together, so thank you so much for doing that. And thank you everyone for joining. And with that, I hope you all have a great rest of the day.
Thank you.